Is it holistic health, where we look at everything from a holistic perspective, where instead of looking at it from a geographical global sense, we look at it from a philosophical sense of universality? Or is it about planetary health, something very, very rooted in the well-being, the health of the planet we live in? Or is it just global health is anything that has nothing to do with local health? Or is it little bits of all of these things together? And therein lies the trouble, because if we cannot define something with clarity, if we cannot say this is what it is and this is what sets it apart from everything else, we are already struggling when it comes to the wider aspects of things like policy making, resource allocation. What do we do in the name of global health?
Okay. Sorry.
Yep. Right. So therefore, when we are stuck with that definition, the issue with definition, and then we come to the topic that you're talking, which is about priorities and seeking whether or convergence, like, we have an issue. So is there something that we can propose to the wider world? And that is what really excites me about today. This is the first of a series of lunchtime lectures by the Global Health Collaborative, which is the brainchild of four amazing people who are seated here, to actually not propose something in the hope that it is accepted, but propose something in the hope that it stimulates debate. And by virtue of stimulating debate, we are creating interest, because people's lives depend on this. So if we are struggling with the term global health, and then, of course, it follows that we have to then struggle with what kind of priorities we are having. So imagine the magnitude of the problem here. We are talking of something that has to be universal. We are talking of priorities that very rarely are universal and apply to everybody with the same sense of urgency, and therefore has the same degree of prioritization across countries, across communities. And then we are seeing whether there is convergence or divergence. So what I hope to humbly propose is that the word global health, if any one of us were to say this is global health, it is health that is entwined, something that is very much integrated with the Sustainable Development Goals. Very briefly, Sustainable Development Goals are a continuation of the Millennium Development Goals that started in 2000. And by 2015, we moved towards the Sustainable Development Goals, a 15-year program envisaging many wonderful changes across the world by 2030. So we are just past the mid-cycle of 2015 to 2030. And when I propose that our concept, our understanding of global health should be entwined or integrated within this, I will try to explain why. To begin with, there are 17 goals. And the third goal, as we can see here, has all to do with the well-being of all ages. It talks of healthy lives. And then within that, there are 13 targets. So if we were to ever go in there, there are very detailed targets that say we hope to attain this point by 2030. And they are very much detailed. But the bigger picture, which a colleague of ours will touch on, is actually all 17 of these Sustainable Development Goals are in one way or the other linked to the well-being and health concept all throughout of all communities. But so is this purely because we have a very convenient framework or a scaffolding on which we can hang a definition? No, it is actually going beyond that. It goes to the very founding principles of the Sustainable Development Goals. when the Sustainable Development Goals were formulated, first proposed somewhere around the 26th of September 2015, they were founded on two principles. One was leave no one behind, and the other was to reach the furthest behind first. We still continue to hear the concept of leaving no one behind, but reaching the furthest behind first has now been dropped. You hardly ever encounter it in literature. Okay, why is that? Because leaving no one behind is relatively, it's a great ambition, but it's relatively easy. It says we are open to anything, come. Whereas reaching for the furthest behind first, literally in this audience, would mean I have to get through all these rows to reach the final person there. I have to actively invest myself in order to reach that person who's furthest behind. And that has proven increasingly difficult. But what I do propose is that if we were to keep these as our basic principles, and if we were to really believe in the fact that this is the way in which we can look at these problems, create a global environment where every single person matters, we have to then look to the basic founding principles and use them as the driving force for global health. So why do we need to worry about this? So let's engage in a bit of a health check. Where are we today? We are in a place where there is a hugely overburdened health and social care system. Management of illness has become a commodity that is available at a price. We are so lucky to have a concept called the National Health Service in the United Kingdom, where in many countries, that's not something that is affordable, that is given free of charge. There is an increased mistrust between the community and the so-called providers of health, and there is even an active revolt against things like public health measures, including vaccinations, which bodes ill health, basically. We have come to a stage where we cannot meet the health and well-being requirements of our communities, and anything that we do in the name of doing that has to overcome layers of not just physical and financial barriers, but the mistrust of the very people who are supposed to benefit from those interventions. And why did it come to this point? So let's take a walk down history. A very, very long time ago, when it came to human communities, we cared for ourselves, very much like the animal kingdom today. People cared for each other. And caring for each other was not just caring for those who were sick, but also caring there was preventative health all the way. So for example, in Sri Lanka, we have loads of snakes, very venomous snakes in Sri Lanka. And what do? It was for the community to keep the roads clean, the fields clean. We worked as a community to prevent problems. And when there was a problem, we found the solution within. The herbs were within reach. And as time gravitated, few people began to develop a specialty. In our culture, we talk of a thing called At Gune. At Gune literally is the healing power of the hand. And some people have it, some don't. And when you are blessed with that power, people come to you just to be blessed. And that is a very powerful belief system that then results in very good outcomes when you are within those communities. So we have these so-called traditional healers, and they exist to this day. There are communities that still rely on those traditional healers. Why are they different? For one thing, they are members of the community themselves. Two, the resources, the sources they use for their day-to-day management, for their work, is all locally based. So this was a model that lasted for millennia. But as time goes on, we began to realize that some of the solutions, we could find better solutions outside. So the solutions now to the problems that were in the local community, we could source from outside. And as this requirement to get things, appreciation of things that were probably better outside in some instances grew, we began to see a situation where the providers of this care, the holistic, the professional healers, began to migrate themselves in order to train. The many wonderful students we have here. You are here in Plymouth today because we have sought to gain an expertise that may not be available in our local community. So we migrate in search of that expertise. But as we began to relate to that expertise, we lost invariably the touch with the local community. So the local community could no longer be known on a one-to-one basis, very much like the primary care, the GP network we have. When I grew up with one general practitioner all the way from the time I was born, literally till I finished medical school. But that doesn't happen now. So what happens is instead of relating to people, we began to relate to disease conditions. And therefore the diagnosis was born. And the moment we go to we gravitate towards diagnosis, we go to curative health, away from preventive health. So now we are not preventing, a majority of our time, we learn skills from outside in order to handle diagnoses that apply to local populations. And as, of course, with that need to create that expert knowledge, to grow it and sustain it, funding was always applied at that central level, which is why we are here as a university. We are here as a university because we have the funding to train the future professionals of the world who come from all parts of the world. But even as we train them, we are losing that connection we have with the local community. And therefore, we come to almost provide healthcare in a very central manner, a manner that does not quite recognize the patient, but the condition the patient suffers from. So now we have the classic example of knowledge transfer. We are the owners of knowledge, and knowledge is always power. We have that power, and we then provide it in a very benevolent way, I may add, to the local community, who now become the recipients or the consumers of our knowledge. Now, this was happening, and we thought we were doing well. Around the 70s, we came to realize, in spite of some countries spending so much more per capita on people, the health indices, like even things like life expectancy, didn't seem to really correlate to the amount of money spent. So public health was born, the Almaty agreements, we came to realize there is something else we need here. We need to understand the causes of the problem. And in order to identify the causes of the problem, we thought we will start getting out feedback from the patients. But the patients, these were called patient-reported outcomes, and those outcomes were essentially patients' feedback on our interventions. So we still provide the knowledge transfer goes on, but at least we are asking them, is it working? Is it working for you? At least we are now looking for feedback. And that we called patient-reported outcomes. As time went on, this alone was not found to be enough, because we realized that the responses we were getting meant very little for us. We would either get, they were based on variables of interest that we asked on. We didn't know what mattered to the public, but we would say, this is what we intend to do. This is our treatment. These are our outcomes. Tell us about your outcome. At least then we moved to this thing called from patient-related outcomes to patient-centered outcomes, whereby we started asking patients or the community, whom should we ask these questions from? At what time of the year should we ask it? How should we ask it? Should it be focus groups? Should it be community meetings? And so on. But still, we were asking about the outcomes where we had the control about the variables of interest. At least now the community began to have some kind of measure in the generation of knowledge by telling us this is the best way to do this. These are the type of people from whom we should seek feedback. And to a great extent, that is what happens right now. We still decide on our priorities. The priorities are quite often decided centrally. We decide on the interventions. We provide the interventions, but we use the patient focus groups to understand how well the intervention is permeating through the society. And that is why we have all this. With that loss of community, the real community-centered connection that we had, instead of that trust that had been built up over millennia, we have lost that trust. So what we are proposing is something else. We are saying we have to engage with the community. And the moment we say we have to engage with the community, it has to become local, because community is a local phenomenon. Okay? We have to engage with the community to understand what the community's priorities are and co-design, co-own any initiative that we then launch. And in doing so, we create this beautiful situation of knowledge exchange. The principle, the key phenomenon, the key principle of knowledge exchange is the recognition that the recipient, in the case of healthcare, has as much to offer for mutual empowerment as the provider of healthcare. So together, we can then create a situation where we can grow as one. And this means we create a solution that works for our local community, where we, our group, are the enablers and the others are the recipients. And this model also recognizes that as much as we are so-called the providers of healthcare, we are also members of the communities that we live in. And that, to me, is, if we were to refocus our efforts in global healthcare to local communities, I believe then we will get to a situation where we can actually have that the point where everybody is feel valued, where no one is left behind. And with time, it won't be immediate. We'll be reaching those furthest behind, even if they are not reached out as the first people at all. And how are we doing this? So this is the beauty. This principle has already been enacted. So the International Students' Day falls on the 17th of November. We started last year a program called Colors for Scholars. Initially, it was meant to celebrate international students, a soft way of celebrating the value international students bring to our local communities in the backdrop of growing negative discourse. I think 1 year ago, international students were overcrowding our system. They were bringing families. All kinds of things were being said. So we said, instead of making big statements, just wear something colorful on the 17th of November to see we support it. We were shocked when 9 countries picked up the message, and we had a wonderful reception. But what we learned over the 300 plus days since was it was like a firecracker. There was a bang, and that was it. Because what we saw in August that even manifested in this beautiful city of Plymouth was anger, was hatred. Anger, hatred, and difference. And why was this? When we look back at our program, we found that even as we celebrated international students who were a subset of our community, we completely ignored the majority of the community. We need to recognize everybody. If everybody wants to take ownership of something, we have to provide opportunities for everybody to be part of. So now we have changed the meaning of scholars. We say scholars are people who are in any community who contribute to the well-being, the unity, the harmony of that community. And why are they scholars? It is because there is so much to learn from them. And if we do not recognize that local knowledge tends to fade away as the persons retire, as they migrate, and ultimately die. And that is happening across all communities. We are losing very, very rich knowledge because we don't recognize that there is something worthy of learning. So let me come back to the Sri Lankan example. I spoke of snake bites. I spoke of the danger the unpaved roads had. No, I'm not talking that entirety of Sri Lanka is there, but definitely there are many, many parts. And this, having worked in Ghana as well, I know it's a global phenomenon. We so had on the one instance, when the communities were responsible for their well-being, people looked after their roads. Two, people developed their own footwear. They knew there were occasions when they would go out where they would use footwear or they would take other preventative measures. What happened with the passage of time? Those people who were developing the type of footwear died, and they took their skills with them. And what do we have now? A society where people who can afford will wear slippers, those who can't wear nothing. So what happens now? Even as this is happening, diabetes is reaching epidemic proportions in the globe, well, all over the world, especially the global south. And one of the earliest complications of diabetes is a peripheral neuropathy, where we begin to lose sensation of our feet, our soles. And when we are walking on unpaved roads, when we do not have footwear, we invariably traumatize. We create injuries to our legs. And with time, these ulcers don't heal. We have the typical diabetic foot ulcers that then lead to amputation. And there is a study that says 85% of people who undergo amputation to diabetic neuropathy die within 5 years. And this is because we have lost that local connection. We should find those people who are creating local solutions to local problems. And those local problems may manifest globally. Maybe diabetes is a global phenomenon, but the way it impacts on those of us who live in Plymouth will be a very special way that is relevant, maybe even be unique in some aspects to Plymouth. And if we do not recognize the people within the community who are holding this knowledge and celebrate that knowledge and actually use that as a key learning objective, we are going to lose it. So we created this, and we said the colors are we want the colors to represent the beautiful diversity of the world, but scholars to be the people who have that vital local knowledge. So just understanding the people alone, will that help? No, we have taken a step further. We have created something called the International Journal Writing Group. What do? We ask for people to come together, look at some point of interest, study the local manifestation, compare it with the global manifestation, relate it to the sustainable development goals, and write about in peer-reviewed journals. Okay, it sounds a very lofty ambition, but it is possible. To do this, we have the library of the University of Plymouth that has helped us identify things called open access journals, which provide us, as long as the corresponding author is from the University of Plymouth, we can publish free. These publications normally take a fee of between $2,500 to $3,000 to publish. But here we are saying we can publish free. But then there is that caveat that the corresponding author has to be from the University of Plymouth. So we have also found a subset of journals called diamond journals, where community researchers, people who may not have any university qualifications or even affiliations, can be the corresponding author and publish. So is this possible? Yes. We tested the prototype. One paper has been published, none other than this amazing Dr. Daniela Oren, who set a seminar. It is a seminar paper because it talks of the ethics of sustainable development goals. A second has been accepted for publication. The third has been given through review. 2 other papers are being written right now. They are not costing the authors any money to publish, but they are multinational collaborations and involve community researchers, the scholars that we want to celebrate. And that is how we feel, on the one hand, we will be creating that local awareness, the importance of celebrating the knowledge within the community, which we do not do now. Where at any stage in life are we told to look at the community and learn something with the idea of developing that for the local community? We have lost that. We want to refocus there. And we want to say, at the same time, we'll publish it globally so that we can learn from each other. And we are developing a map. The university is actually putting so many resources here. We are developing a world map in which we will have pinpoints. And as we hover a cursor over each pinpoint, we'll know what is happening in each community. And our hope is with time, every single human community in this planet will have a point representing something that they are developing locally. That is, of course, linked to the Sustainable Development Goals and comparable against a framework of the Sustainable Development Goals. We have set ourselves a period of 5 years to achieve that. And this program, in many ways, today's presentation here marks another stage of starting it. So all I would request you is to please engage with us. It doesn't matter. This is a photo of a group that we formed just 3 days ago. So this is how it works. In this photo is one person who has lived in Plymouth all their life. Is another person who's an alumnus of the University of Plymouth who went to Manchester, who came back to form this group and will work remotely. Another person is from Nigeria and just joined our university as a nursing student 2 months ago, right, in September. And they have formed the group. We will take you through the stages of finding the perfect journal. We will help you to go through the setup of finding ethics. I just wrote to Daniela, who's our ethics, head of ethics in our university, to say, can we have a uniform way in which we'll do this? Because we are not doing any form of research here. The methodology we are using is called community science. And through community science, it's not research, community science, we are going to get the best of our communities in a way that it can work. So it is happening. And as a result, that is Daniela's paper. It's already been published. And I'm so grateful she put my name in there. I don't deserve to be there, but I am so grateful to be there. And that is the world map as it stands today. Imagine in 5 years, if every one of those blank areas are filled with red dots or any colored dot that tells us that something amazing is happening. This is where we hope to get to. But with anything, you can talk the talk, but you really, if we are to convince ourselves, we need to walk the walk. And therefore, I'm very, very grateful to get 3 people who are here to demonstrate things that have actually happened to give us hope. But even just before I hand it over to them, there is something called the Universal Health Coverage Package that has been formulated by the World Health Organization, which at its very basic level says every human being has a right to a basic amount of healthcare that will not impact on their financial sustenance. They should be able to do that across the world. Again, the target is 2030. And look at what they say. They say we need to reorientate our health systems. And just by shifting to primary care, 90% of the essential interventions can be delivered. The world is beginning to move in that way. We are only saying, let's define primary health care as something that is rooted in communities. Primary health care should be rooted in communities. That is our link. So I'm very grateful that you listened so far, and there'll be a time for questions. But to show how this can happen, we have 3 amazing colleagues. The first, I would love to introduce a retired anesthetist who, please, Mary, you talk about yourself, who's done some amazing work. Thank you.
Right. How do I?
Yeah, I'll press the button whenever you tell me.
Okay.
Yeah.
I'm Mary. I have lived in Plymouth now for 30 years, and it's actually where my grandmother grew up. I qualified in 1980 in medicine, and have done anaesthetics and some general practice along the way. I've worked in various places with people with various levels of disenfranchisement, I would say, which is probably what we're talking about. But I actually, for the last 20 years, I suppose, I've sold fair trade. I used to buy fair trade, and then I felt that I needed to do something about it, and I've sold fair trade. So I have a stall which lives in my house, and I take it out, and it's presently outside, and I hope you'll stop by on the way out. So that's the promotion. But I'm here really to talk about fair trade because I think it can form the basis of everything that PG has just talked about. It basically builds community. So you've seen these, and the one that fair trade is particularly addressing and was designed to address is the first one. Fair trade started after the last war, maybe 50s and 60s. Missionaries, people who were working in the global south, would see artisans making things and bring them back for their friends here. And then Oxfam and Tradecraft, which sadly is no more, came together, started being trading organisations selling fair trade 40 odd years ago, really. And it's developed from that. And it reached its heyday really in the sort of 2000s. And then after the crash, it sort of went down. It's beginning to pick up now in terms of how much is purchased in this country. But anyway, so we'll move on. So these are the fair trade principles as defined by the World Fair Trade Association. And you can see really, actually, they cover the sustainable health, sustainable goals. So it's it's principally about giving people appropriate remuneration for their work and what they produce. So we'll go on to the next one. So I've taken these bits and pieces from the Fair Trade Foundation website, which is the UK Fair Trade Association. And it's about paying people fairly for what they produce, so the cost of production and a wage. And the bit in red is what it's all about, which I'm sure resonates with lots of people. And I think conventional trade has probably only got worse over the last 40 years. So the other thing that happens with fair trade is they have something called a fair trade premium. And this is an amount of money that is paid over and above the fair trade price. It's usually 5 to 10% of the amount of the fair trade price for whatever goods have been imported. And that is paid to communities, not to individuals. So this is encouraging people to group together as communities. That might be a tea plantation, or it might be half a dozen coffee planters, or it may be 100 home workers who are all being supported by a community, helping them to produce their goods and bring them to market, not only in the West, but also in the global South, and build a proper business from it. I mean, there's a little bit there about some cocoa farmers. That's a recent this year. So their cocoa came over here and they got this extra bit to help build community. And if we go on, the next one is, so I've just got a couple of last pictures about some of the people who have been helped with fair trade and what they've actually purchased with their fair trade premium. So the cost of the production of the goods has been paid for, or the food. The workers have been paid a fair wage, and then over and above that, they can build their communities. And we'll have the next one. And this one's South America, Central America. And all of these things. So this one hasn't particularly got health things in it, but every single one of those improves health outcomes. Okay, so health isn't necessarily about me going out and doing something. It's about us, as PJ has said, building the community and building resilience in that community so that their health outcomes improve. one of the papers I didn't, well, I may have read actually, but read about in the 80s that has stuck with me all my life and probably made a big difference as to how I practice medicine was one that was published in the 80s, fairly soon after I qualified, about reducing infant mortality in, I think it was Pakistan. And they discovered the thing that made the difference was making the mothers literate. Forget about the water, forget about everything else. When the mothers were literate, they looked after their kids so they didn't die. And that's it.
Thank you, Mary.
So another seamless transition here. So my name's Tara. Hello, nice to meet you all. So I'm a GP in inner city Plymouth, but I've for the last 10 years had 2 roles here at the university in global health. So one being a master's in global health that we were asked to develop and design, and that has now run for that long. And the second to do with something called the Southwest Global Health Collaborative, which is something we developed in 2016 off the back of the masters and the recognition of how much separate expertise, knowledge, global health partnerships and links, just that we could all bring together, and that we weren't all working together. We didn't even know that some community groups were working with a group in Ethiopia from Exeter while we were setting up a medical school linked to exactly the same part. So it all was sort of pulled together in that way, but then really with its aims to be providing global health education and global health opportunities, or signposting to them, trying to make research more global health sort of oriented. And it's sort of waxed and waned through different things over that time. And this is us sort of reinvigorating it again. So our chairs of the Global Health Collaborative are PG and Professor Kerry Jones here, and Matt Griggs, who's going to talk in a second, and myself sort of lead it. But there will be more things coming from this again. Now, I'm going to briefly skirt you through some of the history of what are convergent priorities in global health over the last 15 years. And it effectively comes down to this. So reciprocal benefits and global innovation flow. But fundamentally, when we all say, what does global health mean? We're talking about the change from our old approach, which was pretty much, very much, the NHS. We've got lots to give. You know, we're brilliant at this, and we will go and we will deliver. And that's our charitable approach to things. Now, Lord Nigel Crisp is a big figure in the NHS, used to be one of the chief execs, and was asked in early 2000s to look at NHS and international work. And very much, he wrote this book, which is amazing, about turning the world upside down. And all through it, it says, oh my goodness, what a load of rubbish. We've been doing things so vertically, like putting money into TB, separate money into HIV, you know, no joined up approach across education or whole health systems and what you need to do. And that's wrong. But also, and what a joke, because the NHS has loads to learn from everywhere. In fact, everyone has loads to learn. If you could take bits, you know, every problem has been solved somewhere. And if you could almost take parts of every health system and they could all co-develop and work together, you could design a perfect health system. But, you know, lots of health services that developed under really austere sort of low income settings do things like PG was talking about much better than we do. And we're going to flick back onto that in a second. So this idea, global health, is actually the world is one. We all need to work together, because in Plymouth, people travel here from any part of the world and see me and GP, having been here for 24 hours, with completely different beliefs, completely different social determinants of health, shaping their whole lives. Different diseases is the easy bit, really, different behaviours and different culture, and all the way we all need to be culturally competent. So then, wheels like sort of this benefits of working in global health have become more apparent. I mean, it's become really obvious that we all health workers need to be globalized in their education. What are we doing not teaching people all these things? But also that there is so many benefits to health systems, from people going and working in different ones and bringing examples back, so many individual benefits. And unless you work across them, you don't see the differences between them. And Lord Crisp would say, train for the job, not the profession, and that we might be very siloed in our education of, say, a GP. How can we not be learning all the other stuff that we might separate and call public health? You know, that it really has to be a bigger, well, we need to understand human resources, and we need to understand all the other bits. Next, thank you. So from this is a very brief summary, but Lord Crisp created something called the All-Party Parliamentary Group in Global Health. Now, initially, it used to be called reverse innovation, which wasn't really probably a very good way of phrasing it. So it's been trained, but the idea that we had lots to learn. So just picking 2 of those reports, and they all apply as well to what PG said. But the idea that we don't empower our patients or ask them to participate in the same ways as countries that might really need to, because we don't have the nurses on the ward unless a family member is there, and then they're there the whole way through. So your readmission rates to your cardiac unit are much less. So he pulls together millions of examples by looking around the world and picking things that we should be doing here. All to do with community health workers. You know, it's something we do really badly. We don't staff our primary care. We say we've got no staff, but we haven't really embraced community health workers here. We need to look to examples elsewhere. And again, to do with task shifting, that we still have this model where we excessively train to a ridiculous level, you know, and then say, well, we've got no doctors, it all must be staffed by doctors. Matt and I work for a practice in Plymouth that's really embracing allied roles. But it can be very difficult to professional barriers and all of this, and prescribing to task shift. Yet most of what we do, like physician associates and these new ideas, they were all developed a very long time ago by other countries. So with different terms, clinical officers, or, you know, in different people who might not move so much between countries, or brain drain. So a book by a chap who runs global health for KPMG recently in particular, so solving the global workforce crisis in healthcare. And again, just all of this is the same thing, talking about how if we don't look globally, and we often still don't, we won't find the answers. But every answer, like, they do not have a primary health workforce crisis like we do in Plymouth in many other countries around the world. And if we look and share and take examples and have this, then things would be far more easily solved. So a very quick skirt again, but off the back of all of that work from the mid-2000s and Lord Crisp's work came the idea, and it's Tropical Health Education Trust are just the body that delivered this almost. So this is government funding for international health partnerships. So for the last 15 years, at least, there's been lots of DFID, Department for International Development funding, going into this, but it was tendered and delivered as such by Tropical Health Education Trust, who typically, as of this month, have changed their name, but you'll still hear that banded around, but now are called Global Health Partnerships, which is actually a lot clearer. And one thing I've put at the top there is that they have really hammered in amazing ways of working, and it's all about co-development and how you would sustainably work together and ensure it's going to last in the long term. But to the point that to get any of their funding, you have to show these 9 principles. And if you ever work in anything global health or go for any global funding bids, you know, make sure you look at them. But when I read them now, I think this is a bit of a joke, because we do lots of our global health work a lot better than we do locally. So, for example, one amazing research thing that's been going on for a while here with a primary care research group to do with Uganda and the midwives, and working there to talk about lung pollution from indoor air smoke when you're pregnant. And they've worked with the arts and illustration department here, designed amazing sort of tea towels that are entirely culturally competent, getting messages across, designed by patients and the community, perfectly adapted. And I think our practice just writes and sends out this rubbish sort of 5-page script with no pictures. It's not relevant, you know. So now I think we almost do things better with our global health funding than we do locally. So it's, again, we're all together. We should apply these 9 principles all the way through everything we do in health. So again, you'd have to look it all up, because we've got to be quite quick here, but, you know, they've sort of summarized what they've done. And it's a real focus on health workforce, education and capacity building, but not just like going back to the old model that we go, we deliver, but the idea of even train the trainer. You have to train people who are going to continue to deliver, or you have to create systems that are going to educate people and not just come and deliver, but make something sustainable that ideally won't then need those people who are creating it at all. It's a bit of a jump, but now we're going to look a little bit at something different. And again, it's going to have to be brief, but we are health research. You know, universities should be doing a lot of research, and sometimes it's not immediately apparent, you know, how health research isn't very global. So if you search your literature, you're not going to find a fair look at everything for everyone. It's often incredibly centralized by high income countries, what you will find, and where the funding's come from, and who's even managed to publish this stuff. So, for example, in the mid-2000s, again, they sort of said, my God, now we've got the internet, we can give everyone access to all the literature we've got in the world, like we've solved health, you know, amazing if everyone can get this. And lots of universities like Toronto, who I worked for, just opened up their entire online library, which is great. Except, you know, people need to be trained, obviously, in how to search, how to appraise, and then how to locally apply it. So we were asked to work with this group of the College of Surgeons of East Central and Southern Africa. There are about 200 training sort of senior but trainee to the progression surgeon sort of level, who would go through this evidence-based medicine and how to appraise things. Now, this is picking one random example, so it might be difficult to apply here. But the idea, this was a global gold standard evidence-based perfect review of something called compartment syndrome. So the idea that it's all about swelling in your lower leg effectively. And if you injure your leg and it swells, it cuts off the blood supply. But this should be, how to manage it should be this. You know, if you were a surgeon in rural Uganda, you should look at this and go, okay, this is what I do. But all our surgeons said, this is rubbish. You know, this doesn't apply to us. Like, it doesn't even mention someone who's not very well trained putting on a tight plaster cast or snake bite. And it doesn't, you know, it talks about using this pressure monitor, but actually we couldn't do that because we don't have anything to sterilize it. So they would pull apart and laugh at the concept of evidence-based medicine in a way that I've never really realized before, and would very much be left going, oh God, yeah, you're totally right. You know, this research is not relevant to you. Why would you think evidence-based medicine was a good idea? So just have that in your mind for any research. So again, jumping slightly, but, you know, this is, universities have a responsibility and we need to push to get these responsibilities through. So medicine and this UAM sort of pulled together. And I just put it in because it sort of shows what we should be doing and some examples of what we should be doing. But, you know, are our university investing in research that might be for the best interests of countries other than here, for example, like leprosy? Or, you know, would we do that at these neglected tropical diseases and other problems that aren't a problem here as such? Then it's all about how you license your things and how you publish them, and a bit like we're talking here with the Journal Club. But, you know, you have to have this at the focus of everything. And we keep finding that even if we shout about it, it is missed from lots of other things, and people will continually skip off it because it's not straight down the line affairs. So global health should be in all undergraduate and global and postgraduate curricula now, only recently, but it doesn't really come into many, and it keeps being skipped off or pushed aside even by the medical school. So I think it's something we continue to shout about, and again, keep all those little bits that you've just had tidbits of in mind. Right, seamless transition number 3.
Hi. Right, my name is Matt. I'm going to talk very briefly. I'm aware that we're nearly coming up to our hour slot. We are around for another half an hour. People want to hang around for questions afterwards, but we will try and wrap up within there, I promise. So PG asked me to just give an example of one small project within the university that's linked to the ideas of working in community-based global health. So I'm a paramedic by profession. As Tara said, I work in primary care here in Plymouth, and I've been a lecturer here for some time now, starting on the paramedic course and then moving over to global health within the med school. Now, I want to introduce you to this chap, who is Dr. Van Gautam, who Peter up there also knows very well. Now, Aban comes from a very humble background. He studied at a school that he had to commute by walking fairly long distances to every day, and then achieved funding to become a doctor at Kathmandu Medical College. Shortly after graduating, he went off to respond to the 2015 Nepal earthquake. And it was only when he's there that he really started to appreciate the complete inequalities in the provision of healthcare across Nepal. And so he set up, he's an incredibly entrepreneurial guy, and he set up an organization that I should have put up here called Mountain Heart Nepal. And they started to respond to sudden onset disasters in Nepal, which happen at an alarmingly frequent rate. If anyone knows, there was a massive flood out there a couple of months ago that killed about 250 people, similar to the ones in Spain, but we didn't really hear much about it. And he set up this, it was more sort of setting up primary care, basically, in response to these disasters. It's very difficult to respond in the immediate aftermath, but he set up this sort of longer term, sort of 3-4 week later system where he was able to give something to the local communities where their systems had been wiped out. So he got a bit of a name for himself. setting up this charity. And then over the past few years, he's been developing this hospital up in the top left-hand corner called Siddhistali Rural Community Hospital. And he's done an absolutely phenomenal job in setting up this hospital. He's been totally self-financing. He's arranged charitable funding through charitable organisations such as Rotary International here in Plumpton, but also international organisations as well. And he opened up the hospital a few months ago now. So he started taking patients in July this year. And it's in this sort of rural community area within the sort of southern districts of Nepal, not far from where he came from. His next project is to set up this slightly curious picture, but he set up this local community hospital, at least has the planning and now has the permission, in the beautiful Langtang Valley, where if you become ill, you've got, at the moment, you've got a minimum of sort of a 2-day, very uncomfortable journey on the back of a mule down to the road and then several hours drive to get to the nearest healthcare facility. So he's received approval to set up this health clinic right up in the valley, which should serve a community of about 3,000-4,000, and then all the many tourists that go there as well. So how do we link in with Aban? Well, Aban, when he was responding to the earthquake in 2015, came across somebody from University of Plymouth, and he got talked into doing an MClin Res here. And whilst he was doing an MClin Res here, he came and spoke on the global health course that Tara was working on, which a colleague of mine in the paramedic program was also then a student on. And I had also been out in Nepal after the 2015 earthquake and had been just down the road from where Aban was in a very minimal role as a paramedic out there. And so between us, we started to sort of just speak and work out how we could work together in some way in Nepal. And we ended up in 2018, myself and Jason went out there and we started looking at around the model that Aban had of setting up first aid community-based training programs. COVID killed that pretty shortly after 2018, but we reinstigated it. And last year, we took the first Faculty of Health field trip, as it was designated, out to Nepal. And we worked with Aban in his new hospital. And we continued the program of first aid community training. And we also, with him, developed protocols in the hospital. It might sound quite grand that some paramedic students go out there and work and writing protocols for a hospital, but they just experienced 3 years of very difficult times for the NHS. And they'd been witnessing all the, people coming into emergency departments and all the challenges that they had in trying to process so many people. So they actually had a very good understanding of ED departments. And so with Aban, we wrote out how he was going to organise his emergency department. And also we ran a focus group that looked at, and this brings it back to the beginning, that looked at what the community wanted from the hospital. So this is a rural community hospital. And the focus group was for a student on the global health programme here. And we just set into 2 groups, into female and male groups, and just asked them what it is that they wanted from Aban's hospital. We've now, that's just been submitted as an MSc dissertation, and we're now sort of trying to republish it and publish it through the journal club that PG was talking about. And then finally, and I promise this is the final slide, this then led, when we were out there last year, we worked with the Nepal Ambulance Service, which is a very grand sounding organisation that isn't quite so grand in that it has 10 ambulances for a population of 30 million people and does as many jobs in a day as a service as one ambulance does here. But we were doing some training with the Nepal Ambulance Service, and they were reasonably well trained. They're a charitable organisation. And they've been gifted so much equipment. Their storerooms in Kathmandu are better equipped than a lot of ambulance stations I've seen around this country. But it was completely underutilised. They're not using this equipment. It was very ill-considered charitable donations, really, just throwing this equipment at people that weren't necessarily going to use it appropriately. When we were working with them, they had the knowledge. They definitely had some of the skills, but when we spoke to the emergency medical technicians, they weren't really using the skills. And we were saying, why aren't you using them? They said, well, there's no acceptance really within the community of any treatment being done before they get to hospital. So you turn up to see a patient, you start working with that patient, and the family just said, what are you doing? What on earth are you doing here? Get them to hospital. And they get hurried out the door. Similarly, on a road traffic collision, a lot happened in the pool. Crews were going there and they wouldn't touch any patient unless the police were there for fear of litigation, because the minute that they had any contact with those patients, and if the prognosis was bad and they ended up dying or being immobilized, then they would be liable for any of the costs involved with the healthcare of that patient. So this led on to my own little project, which is now looking at that interaction between, I've just started a PhD, and it's looking at that interaction between the community and the emergency healthcare workers. So looking at that interaction and trying to see what it is that people either want from their emergency care system or what they feel they need within their smaller communities, but also what they feel they don't need. And coming back to what PG said, you know, they're still very, very highly reliant on traditional medicine. There's over 50% of the people in our focus group, their first port of call in healthcare was still traditional medicine. So it's the role of that. And it's also the concept of leave no one behind, the furthest away first. I hope to be working in the far western Nepal, which is the least developed area of the country, to work out how they view emergency care. Because for them, if they need something that needs a high level of intervention, like a burns care, then they have to be transported to Kathmandu, which is a 48-hour journey with absolutely minimal treatment before they get there. So hardly any pain relief and very, very limited treatment, to the point that they get to Kathmandu and their prognosis is so poor, they lead to a lot of amputations. So working with those communities in far-flung places, but also comparing that then to the more built-up areas within Kathmandu to see if there's any difference between them. Right, I think I'm going to shut up. Sorry, that was very, very quick. And I realise we have been here for a very long time. But if anyone has any questions for PG or myself or anyone, please ask away. And in the Zoom, if you have any questions, please do put them in the chat or just unmute yourself. Any questions? Oh, sorry, Danielle.
So thank you very much for these very, very interesting presentations and to highlight the different initiatives Plymouth is doing. One central question, which I have always asked myself, is really, how do we address the power hierarchies that persist in health research and priority setting, even when community engagement is emphasized? When we consider the self-preservation of healthcare, because at the end we are not caring health, we are caring for ill health or absence of health. And very often what I see in research development and priority setting is there is a driver from healthcare providers to advance their profession and to certainly not extinct their profession. So I'm having a background in optometry, and a very good example is we know myopia can be prevented or less progressed when we send children outside. But now we are spending millions of pounds in virtual reality who basically simulates outside world. So why not just sending people outside? What prevents us as researchers and healthcare providers to accept this knowledge? And how does this influence our priority setting?
PG?
It's a very good question, and for the benefit of the online audience, the question was, how do we influence the prioritization of research? And the case study was myopia, which is rampant in communities. And there is evidence to suggest just going out, engagement with the wider world, engaging with distance vision can actually prevent myopia. And yet we are spending millions sending virtual reality equipment to countries in the name of education. And that truly is the issue, Daniela. I think part of this conundrum we have is there is a thing called publication bias. And publication bias is also driven, among other things, by the funding. You know, to do research, we need funding. Then to publish research, we need funding. So how do we do it? And that is where, by focusing on the community, on things that are already happening, we are not recreating interventions. We are looking at things that are happening with the community. So, for instance, one of the researchers one of the areas we are looking at is the impact of child abuse on adults in our community. We have an amazing person who has first-hand experience of child abuse. We have another who has served in organizations that care for those who have experienced child abuse. And we have a group of others who are looking at it from a more holistic point. And by doing that, we are not it is, of course, the goodness of our heart that we are engaging with this. But we are trying to look at how it manifests within our community and how the centralized interventions are impacting on it, and how our own local community could do things to ensure, one, to prevent it, and to ensure the complications of it, to minimize the complications of it. And then, as you said, by virtue of being able to publish this free of charge, and also acknowledge the primary sources of information as corresponding authors, we are trying to claw back that power. And by doing that at a local level, but reproducing that model globally, we may be able to change this narrative. It will take time. For me, we submitted 6 papers as a pilot phase. 3 were accepted, 1 published, 1 about to be published, accepted, 3rd has just gone through review. That is that is an achievement. And I would love all of us here to, including those in the studio audience, online audience, to consider instances in your own communities. Things like myopia. It is wonderful if we could compare different communities and different manifestations of myopia, because myopia by itself is one condition, but the way it impacts on the lifestyle of those and the life trajectories of those who suffer from myopia will change from community to community. And that would be, and what I'm really grateful for is that we have people within our community, both within the university sector and both outside the university sector, who are willing to invest on this, because we can only invest our time free of charge. And that's a big asking. That's a big asking. But if we are going to change, we have to change from the roots. And if we begin to create that mass of knowledge, where people turn back and say, we never knew about this, just like what Matt said about the local community, that paramedics do not want to actually touch a patient because of the local beliefs. But yet they have the ambulances and all the equipment. But no one realized that this will not be effective unless we cross that barrier and recognize the real manifestations of well-being and ill health within communities. We are not going to get there. But thank you for highlighting that. We are fighting, but the beauty is Colors for Scholars was reproduced in 9 countries last year. It has reached at least 20 more countries this year. So it is spreading. Thanks. Do you want to add anything?
Oh, I could warble on for hours. I feel like I probably shouldn't just.
Come.
What about this as well? Well, I guess it's just one can't help but think about journals quite similarly to how one views globalization in general and multinational companies, can't you? And that's actually for this, sorry.
Online. Yeah.
But that, be it whether you look at any profit-making enterprise who is bound by that, and so drugs companies, cigarette industry, and it feels so wrong that one can only publish things normally if one can pay. but also that what we find with lots of that health partnership scheme and these international health partnerships is that the people who are involved are not the university people who are going to publish it. So it's repositories of information, isn't it, on that site that might show examples of innovation that are very little research, little art, you know, that aren't really published because those people are budding sort of clinical workers, not academics. So it's how we span all of those, isn't it? And how we, I think the only way to get those across is through local, repositories of information and ways of finding that information, and not always through published journals that feel difficult sometimes. So
Okay, are there any more questions? Anyone here in the audience or online? Okay. Well, thanks everybody for joining us. We hope to be running these every month or so. We'll keep people informed in the same way through email and broadcasting across the university.